my pleasure to introduce Dr. Tom Simmer. Dr. Simmer is the Senior Vice President and Chief Medical Officer for Blue Cross Blue Shield of Michigan. And Michael Harding. Mike is the Deputy Director for the Washtenaw County Community Mental Health. And the format for this session is they're each going to get up and present, and then we'll kind of go to the next person, and then we'll save sort of the questions for the end. And if our third speaker, Renee Smith, who is the Global Director for IT Enterprise Planning and Portfolio Management for Walgreens, and also one of the board members for Direct Trust, if she gets here, we're going to put her in right at the end, okay? So with that, I'm going to turn things over first to Dr. Simmer.
Thank you, Tim. I'm going to try to press all the right buttons here. I understand I can do a lot of damage if I press the wrong ones. I won't be representing the technical side of this topic. I want to sort of start off by saying all of us are attempting to create value, and I'm going to be looking at value from a bit of a global perspective and get down a little bit to specifics about adding value from the standpoint of adding revenue to practices that are actually creating greater value through their practice arrangement. But all of this challenge of adding value, creating value, hinges on better information flow and incorporating that information into the care process. I mean, it really is down to that. And I'm going to try to demonstrate how that connection by looking at the key challenges for population management and showing how each of those challenges connects with information flow and process management. First of all, we have to start off, and I thought Dr. Kendrick did a great job this morning talking about the patient-centered medical home, which is sort of the encapsulation of the care model transformation that's going to create a lot more value. That care model is not a freestanding thing. It depends on other things to support it. And he had a wonderful slide with the falling diamond, and there was one end that propped it up that said that you have to have a payment model that sustains it. This is not something that you can achieve without a sustenance from the payment model. The second thing you need to support it with was really information. So when we look at the healthcare delivery system and we look at what are the root causes of its deficiencies and lower performance, the challenges relate to poorly aligned payment model, lack of population focus. Practices do a good job with each individual patient, but the care of each individual patient isn't properly illuminated from information about how are we managing our entire panel and where are we not focusing efforts where we could and achieve better outcomes for the patients that we're responsible for, whether it's at a practitioner level, a practice level, or at a health system level. Fragmented healthcare delivery, weak primary care foundation, lack of focus on process excellence. We rely too much on our professional knowledge, attitudes, and skills, and the harm is occurring to patients because of process breakdown. And then the passive role of the patient in healthcare delivery and the passive role of patients in really taking control of their own health. In the bold here, I tried to sort of highlight how each of these root causes of system performance failure is connected with lack of good information flow. So when you're talking about the lack of population focus, the ACRES file is really each practice knowing the complete list of people that they are responsible for giving the optimal care experience to and achieving the best clinical outcomes. Without knowing the population that you serve, you cannot compute rates, you cannot really measure your performance, and you cannot refocus your efforts in a proactive way. So the ACRES file is really key, knowing your practice. The registry function allows you at the point of care to know which recommendations you have for those patients and to assure that each one of those recommendations is actually offered to the patient. And you use that same registry to outreach to those patients who are not actually taking the initiative to get on your schedule. You need to outreach if you really want to have a high hit rate for the recommendations of care that you wish to offer actually being received by the patients. And the patient portal is the means by which you send out that outreach information. So you can see when you go down these, I won't go down each one, but each one of these is dependent on information flow. Now the payment model is really important, and we now recognize that a lot of payment models really relate to how well you're doing on a population basis. So accountable care organizations, capitation, and our value-based reimbursement through the Blues all focus attention on you get money based on how well you're performing on a population basis. The last one here is the remainder of the legacy payment model, which is the fee-for-service model, which does not depend on how well you perform on a population level. And I will go into more depth as to why this really is the payment model where the wheel is still turning but the hamster is dead. It's just not a payment model that sustains practice going forward. Now let's look at this slide from the McCall Institute talking about what is the practice model that we need to sustain. And there's two key sentences about that practice model for primary care. The first is the primary care practice has a relationship with the patient over time and across settings of care. That relationship over time needs a longitudinal record, but across settings of care needs new sources of information to inform the care process. Otherwise, we are not acting as a strong primary care foundation. The second is that the encounters in a patient-centered medical home are actually productive interactions between an informed, activated patient and a proactive, prepared healthcare team. That does not describe current reality. In order to get there for either of those 2 points of patient-centered medical home, and of course you can go through the many domains, but fundamentally we have to transform clinical practice, and that transformation cannot take place without information flow. I'd like to use this slide because it shows for each of our physician organizations, which is what the PO stands for, no matter how few admissions are connected with each one of those physician organizations, and the number of admissions are the blue histogram lines, even when those number of admissions fall to very low numbers, the number of hospitals depicted in red remains high. The lowest on this graph is still above 80 different hospitals. People think that their patients don't wander far. That's because they don't know where they've wandered. Every bit of data that we have, and I could show many different slides, patients go everywhere. If you want to be responsible for your patients across settings of care, you have no choice but to connect. And that's why the very first thing that we connected with is the admission, discharge, and transfer process. And that process requires ACRES as well. So we keep getting back to, if you want to be informed about what's happening with your patients, you really need to connect. This slide shows the Blue Cross Blue Shield of Michigan payment model for primary care practices, where 100% is our standard fee schedule, and the rest of these are mechanisms by which the primary care practice increases the fees that we pay. And starting on the 1st of next month for primary care practices, for all of the E&M codes, both inpatient and outpatient, E&M is evaluation management, which is the bread and butter, 75% of what they're paid, that pay level can get up to 140% of our standard. It's 10% for just being PCMH designated, another 10% if on a population basis the costs are lower. There's a 5, 10, and 15% for quality, and another 5% for having healthcare teams according to our standards. So this is how the hamster's dead, because if you are not performing, you're performing at 100%. That 100% is the fee schedule from 2009. We haven't changed it. How long is that fee schedule going to keep you in business? It doesn't. The only way that you can be sustainable as a primary care practice is get with it, get the information flowing, and qualify for a payment model that's simply far more generous. This is my most important slide, so I want you all to pay attention. The health plan here is the guy. The practice or the physician is the turtle. The health plan is playing the very useful role of encouraging the practice to move forward. Through the hoop, Bob, through the hoop. And you look at the most intelligent thing about this slide, it's the look on the turtle's face. Because that turtle understands the dynamic here. He's going to be torched and ready for turtle soup. He doesn't need encouragement. He doesn't need motivation. He needs help through that hoop. And in our state, that help comes from physician organizations that act to provide the help to that practice. I guarantee you those practices cannot do it on their own. If the physician organization is not able to help and facilitate, the outcome will be very predictable and it won't be a happy one. So what needs to be done to help these practices? And I think Dr. Kendrick also stated, information flow is not the doctor's responsibility. We're back to healthcare teams, we're back to medical assistants, nurses, others, taking the information in and incorporating it into the flow process. Please don't call a meeting of all of your doctors to tell them what they need to do to make this successful. Identify the people who need to support the process of bringing in the information and incorporating it into the patient flow. So what are those elements? The first is the practice needs help in creating the active care relationship file. The active care relationship file has two major components: information about which patients are served by that practice and information about the doctors to complete the provider directory. That means you've got information coming from two sources. The practices can't handle that. They need someone from another organization to come in and help them do it, and then they need to understand the importance of doing this monthly. Secondly, facilitate the implementation of the admission, discharge, and transfer process. Once you have that ACRES file in, you can start to get your admissions, and those admissions need to lead to transition of care management with MedRec and the like. Practices have a real hard time doing that because it means somebody has to check that information daily. And it isn't totally user-friendly right now because it relates to so many messages for each admission, but it's very useful information and it's far, far better and it is actionable. Finally, facilitate the development of point-of-care use of registry information to assure that all patients who are coming in get all recommended services. You don't want to close your gaps in care without having a process to routinely prevent gaps in care from happening originally. And that prevention of gaps in care is point of care and outreach. This is very infrequently accomplished right now, but when we're talking about all this, these new Medicare performance payment models, they all relate to being able to improve these. And I guarantee you that your Novembers and Decembers are already too busy to close the gaps in care over Thanksgiving and Christmas holidays. That type of mad rush at the end is just all too common, and it's not going to get you where you need to go. Finally, there's the promote the capture of supplemental information. As it turns out, all of these measures, for some unknown reason, the claims data simply misses a lot of it, and you get lousy scores if you don't have supplemental data. You heard a lot of talks today about how we're going to be using the QRDS, QRDA type of Category 1, Category 3, you name it. We're going to be sucking that up and sending it out. And that supplemental data will be the difference from people who look like they're performing well and people who really look like they aren't. And that means people who are paid well versus people who are not paid well. And then the care of patients across time and settings of care requires much more process management and does imply a team-based care. So make sure that your office practices have the people they need to make this happen, and try not to overly burden the healthcare professionals who are really managing the level of patient care where evaluations have to be made and decisions have to be made, rather than routine processes that have to support daily care. So that concludes my slides. I just wanted to emphasize that as we are seeking value creation, the role of everything that you're hearing about in this conference is central to that theme, and achieving it will be the difference between practices doing well financially and practices doing poorly that way. Thank you.
So I'm here to talk about the perspective from a community mental health agency. We're not a hospital system. We are boots on the ground, and not that a hospital system is not boots on the ground. Just we are the ones that have utilized this technology to share behavioral health information with primary care setting and with hospital systems. So this is the perspective that I'm coming from on this, and not only that, but from being able to view the physical health information and how valuable that information is for us as a behavioral health entity to be able to have access to that to do some pretty cool things to improve quality of care. So in Washtenaw, we were able to implement, so in 2014, Michigan implemented the shared consent model for sharing of behavioral health information. What that did is that catapulted us and gave us the foundation to and what that law is basically it allows for us to be able to share our behavioral health information to multi-party extent. And if you receive that consent, you must get that. You must accept it. So what that did for us is it said, okay, now our consumers going to other hospital systems or primary care settings, they can actually, they must accept this consent, and our consumers don't have to consent multiple times. But it wasn't good enough, because those systems did not have access to be able to view that consent to know that they had already consented to that. So the consumer was still having to sign the consent multiple times, or the primary care office was having to pick up the phone and we were having to fax it. So while it was great and it's a great start, we had to do something different. And what we ended up doing is building an e-consent management system within Washtenaw. And that e-consent management system allows our entities to be able to log in and view the consents that are in place if they have consented to that particular entity. What that did is then build a foundation for us to be able to then share behavioral health information. So there's two perspectives from this. There's a perspective of us as a CMH system of being able to view the physical health information, but then there's a perspective from the hospital system, the primary care setting, the physical health setting, to be able to view that behavioral health information. Both are extremely important to view that holistic view of the consumer. So from us as a behavioral health setting, viewing that physical health information and getting lab results and ADTs directly into our system it has changed the way that we deliver care. I was just stating to somebody right before this, is our ADTs had gone down just for a half a second and our phones lit up, because people have become so reliable on these ADT notifications, because we need to be able to wrap our behavioral health services around the consumers to make sure that they're successful in implementing the discharge plan from the hospital. And when they don't have those ADTs, we don't know, and we're not able to be there for our consumers. And the ADTs are nice only as an indicator to prompt somebody to go in and view that physical health information in the HIE. That's how we're using that information. They get that ADT, our physician, our case managers know that they got to log into the physical health HIE system, in which we've implemented some pretty cool technology to have single sign-on to be able to do that. So that, because our adoption rate when we had this, we've been at this for approximately 3 years, and our adoption rate was pretty low. Our staff were not willing to log into a separate system to view this physical health information. Not that they weren't willing, it's just their process and their workflow was such that it didn't allow for that amount of time, and that was a secondary piece of their workflow. When we implemented this single sign-on, it actually allowed them right within our record to click on something, and then they were automatically in the physical health information for that particular consumer. Really slick stuff, and it's changing the way that our case managers view our consumers, not just looking at the behavioral health information, but also looking at that physical health information, because so often that is a good predictor and indicator of their behavioral health information. Our lab results are phenomenal in our system. I spoke a couple years ago and talked about the cost savings. I'm telling you that getting those lab results directly into our system is it's not just about the money. It's about the quality of care for our consumers. Our consumers are not having to go and get the multiple pokes, and our prescribers are able to do real-time prescribing because they have that information in front of them to be able to make that real-time decision and not have to wait for our consumers to go out and get that lab drawn, get the results back, and then hopefully the consumer, well, first of all, hopefully the consumer goes and gets that done. Secondly, hopefully they come back to get that prescription filled or renewed. So that getting that physical health information into the CMH system is extremely important. That's the easy part, and I'll talk about that in a minute. The hard part is getting the behavioral health information to our external entities, the physical health providers, because of the extra protections under 42 CFR Part 2, that they have to consent and identify them to whom they wish to share this information with. That's where that e-consent process comes into play, and I'll talk a little bit about that in a minute. What we've done is not possible with a lot of these strategies that we've put in place and a lot of the partnerships that have been put in place. MiHIN, Great Lakes Health Connect, PCE, Alterum, and then of course Washtenaw County. And when we were going through this, we didn't have money. We're a community mental health that has restricted funding. We're not a large corporation that has just a huge technology department. We're a technology department of one, me. And you saw my title, Deputy Director. Also CIO. So you get the gist of this wasn't possible with just one person. You need these partnerships to be able to have the same vision of the improving quality of life, and that will get you to the end. Education and engagement, this is not a small piece. So let me jump to technology first. Technology, and you guys are probably going to throw rocks at me, but technology is the easy part. Once you get the technology in place, it's there. And of course, it has to continue to get upgraded and all that. But the hard part is engaging the people that actually use this technology. The hard part is actually engaging the consumers, especially on the behavioral health side, of why it's important to be able to share this information, why it's important to be able to sign that consent, and why, so that you don't have to tell that story over and over and over again. So the people that are involved in your care have access to the information to make a holistic decision about the quality of your care and help improve that. So the engagement piece takes a long time. We've been through it, we've been at this, and it's still continuous. When we ventured into the physical health, when we ventured into the primary care settings, the clinics that I'm talking about, they don't even know what HIE is. They say hi. So you have to so it starts with engaging the smaller clinics, the providers, and then their consumer base. This piece, so we've had a project fail, and it's okay that it failed, but it failed because we did not do workflow analysis on it. We thought if you build it, they will come. That's not true. We had the technology, we have the HIE up, and nobody was using it. And the reason being is because we didn't have the resources to be able to do a full workflow analysis of how this would be implemented in that particular clinic, how to obtain consent. So since then, we've learned a lot from that process, and we put an enormous amount of resources, people resources, not necessarily money resources, into this workflow analysis to make sure that at that front desk, they're getting that consent, that engagement strategy is there for that consumer to understand that, and you gotta understand that our population of consumers are very vulnerable. It's important that they understand what they are signing on to when it comes to getting their behavioral health information out there in the health information exchange. They can't sign this just not knowing what the risks are involved in it, but approaching it from the positive approach of why it's beneficial. And of course, leadership. You know, none of this is possible without people like you in this room to keep carrying the torch. The torch will die if there aren't people and voices speaking up about this. And proof of concept, when I wore my deputy director hat, this stuff started to slide because it's just not part of the culture yet. And until it becomes part of the culture shift, you need that leadership to be able to carry that torch. The approach that we took is we started with our consumer base, our CMH consumers. That's the heart of everything for in our world. And then we expanded and went on to the hospital systems. That was not our original strategy. Our original strategy was to go to the CMH contracted providers. We then realized, well, our CMH contracted providers already have access to this information through one means or another. So let's flip that. We can get the biggest bang for the buck for going to the hospital system. So we reached out to the University of Michigan and St. Joe's, Ann Arbor, to figure out how to get the behavioral health information into their hands, and they were already contributing to the physical health information exchange. So once we had them onboarded, the next thing to do was, okay, who are our primary care sites that are our consumers frequent? And those are our FQHC, Packard Health, and then we wanted to get see how far we could stretch this project. Now this was funded through an ONC grant where we're in process of, but we wanted to see a proof of concept here. Can we do this at the homeless shelter? The homeless shelter has a clinic within it. And can we get them onboarded into the HIE, and can we get the behavioral health information into their hands? Because oftentimes our consumers are visiting those homeless shelters. And then, you know, secure housing is a good predictor of someone's behavioral health and physical health. If they don't have housing, they're not going to do well, and it can spiral downhill from there. So we wanted to get the information into our Avalon housing area. So those three sites gave us a nice mix of trying to get that information out there. There's another part of this project that is not part of this project, but we also are partnering with our sheriff's office and our juvenile detention center to get the information out of the corrections system that are within their medical facilities into the health information exchange. Oftentimes our consumers end up in the corrections system. When they go into that correction system, they do not have access to the information like what we would as a healthcare entity. They are a healthcare entity within that correction system, but then when they're receiving treatment in there, it's a black hole of treatment, because when they come out, we don't know what health care they got within there. So it's important that our correction system, in my world, that they are connected into the HIE. This is my non-technical rough diagram to show how this technology is working. And so you see the physical health side, it's pretty easy. It's a straight green, it's not gonna work, straight green line right to the physical health, because in Michigan's an opt-out for physical health information to share. You do not need a consent to share that physical health information as long as you're, for the purposes of payment, treatment, and coordination of care. So that one's an easy line. You see where it gets crazy is in the behavioral health line. So our PICS, the HIE for the behavioral health, has a connection into the e-consent where it goes out and it checks, is there a consent in place? Is there a consent in place that matches that particular entity that is requesting this information. If not, return 0 results, meaning the consumer doesn't even look like they exist in the system. If there is a connection, or if there is a consent in place, then what it will do is it'll then query our electronic medical record or whichever other community mental health electronic record, and then return those results back to the portal. Unfortunately, right now, it's not a perfect world because we do have 2 portals. We have the physical health portal and we have the behavioral health portal. In a perfect world, those would be all one. The best we can do right now is we're trying to do single sign-on between those portals so our end users don't have to log into multiple systems until that information is able to be shared amongst each other and policy is changed. There's a whole nother project that I'm not going to get into. We're looking at a social services consent where that consent can be shared among all entities. So from my perspective, or from a CMH perspective, Dr. Simmer was talking about the data that comes through Blue Cross Blue Shield. In our world, we have Medicaid consumers and we have uninsured consumers. And unfortunately, we have many uninsured consumers that don't, that there is no one to submit data to because they're uninsured. And when they go out into the community and receive services, that data is only kept within that particular environment. Now, it might be that that environment is connected to a clinical record that can communicate with the HIE, but it doesn't mean that any population health data or service data or encounter data is going anywhere for anyone to analyze. And that's critical so that we can be able to track the consumers to make sure that they're getting the care that they need and for care coordination. I already talked a little bit about the community corrections and what we need to do there. Our homelessness and connection with HMIS system, so the homeless data collection system, that information is being collected and it's not being used in the clinical hands to be able to give to the clinical folks so that they have that information. That says Michigan continued focus. One of the big things that we need to do, so we're part of an affiliation where Monroe and Lenawee counties are on the border of Ohio. And from our perspective on the ground, we don't have the integration between the states just yet. Our particular health information exchange is not exchanging with the one in Ohio. That's very critical for border counties to be able to get that information, not only for residents within Washtenaw or where they receive their care, or Michigan, I mean, we have to have that so that we have that holistic picture. And then the HIEs within, communicating back and forth, and so that if one of our consumers goes over to the west side of the state, that information is available in an HIE regardless of what that looks like on our end. Provider education, so I think in general, when we're talking about health information exchanges, that it's important that everybody, that it's coming from up here. You know, it's one thing for me to go down there and talk to this primary care site, but it would be really nice if the feds or the state of Michigan did a PR on health information exchanges and talked about what they are and the benefits of doing that and sharing that information. And then, of course, we need more resources on patient engagement. And that's it.
Thank you. That was a great presentation. My name's Ellen Bunting. I have a question for Dr. Simmer. I know the point of your turtle slide was that the turtle needed help, but I do wonder what you think the best encouragement is to get the practices and physicians on board. If it were just a matter of making 140% of the fees, then probably most practices would be getting that. But I don't think that they are.
Ellen, tell me if I misinterpreted your question, because I actually could be thinking that you were asking one of my favorite things to think and talk about, in which case it might not have been true and I'm projecting. But when we're talking about a health plan assessing performance on a population level. In truth, we're talking about how well the disease burden in that population is managed. These are risk-adjusted costs, which means, ironically, that if the actual health of the population were to improve, the risk score would decline and the expected cost would go down. So that the performance really is how well did the delivery system manage the disease burden to the best of our ability to risk adjust. And I think we do a lot of talking about we're paying for population health, but what we're really talking about is a delivery model that was designed and constructed to treat the disease burden, particularly the acute disease, and it's sort of getting better at chronic disease. The reality is that all of that work performed by the delivery system only touches something like 20% of the determinants of whether or not you are healthy, have good activities of daily living type of capabilities, and whether or not you're likely to live a long life. The things that really account for our health are things that are more under our control from the standpoint of nutrition and activity level, as well as those things that are sort of beyond our control, perhaps, whether or not we have a job, whether or not we're homeless, whether or not we're educated, whether or not there's just so many factors that go into it. But those factors are extremely important to the health of the community, but they only indirectly connect with what we pay for in healthcare. So we do have a dilemma here, and I think that the state is doing its best to say, we want to have two things going forward. One is a community-based effort to improve health, and the other is a care transformation effort to improve how we perform in managing the disease burden. One thing I would like to caution is that most of us who are trying to solve this problem are healthcare professionals who are looking at the problem through the eyes of our own training and perspective, and we do have the same penchant like everyone else that if all you have is a hammer, everything starts to look like a nail. So we try to do things like address childhood obesity through a pediatric office visit where people are informed about nutrition and so forth, when the most effective way to address pediatric obesity may well not optimally be cared for in a healthcare delivery setting, maybe schools, maybe other community approaches. And the reason we tend to go to healthcare delivery is because it's a funded process. We can bill for it, and that solves one major problem. The problem is there's so many other social agencies like schools that, for lack of just small amount of resources, they still feed the children in those schools unhealthy things. They ingrain unhealthy habits, and we have to be very thoughtful before we always turn to the expensive healthcare delivery solution to solve the social determinants of health. And so I think it requires a broader discussion. I don't know that we're equipped here to do that, but it is a dilemma that every pediatrician, internist, and family physician feels is, what is my role? Is it the role of handling the disease burden and focusing on that, or promoting health and focusing on that? So I don't know if that was your question, but that's the one I like to answer.
That was a way better answer than my question.
All right. Thank you.
This question is for Dr. Simmer as well. Dr. Simmer, can we, as both consumers and providers of healthcare services, find a time when we'll begin to create public service announcements for the consumer relative to health information exchange and everything that's happening currently in the state regarding this matter? Because there are so few, if not none, none of that is being pushed out to the consumer. So can Blue Cross perhaps consider that type of a communication plan that will address the consumer and use the PSA approach as that vehicle?
Thank you, Eva. I do think this whole notion of informing the public is a really important one. One of the most frequent questions that I get from our customers is, I went to a patient-centered medical home practice, and it didn't feel all that different from when I went to a regular practice. You're paying these practices more. How do I feel like I'm getting value? And it's kind of funny, but I then start probing and saying, well, the last time you went to your doctor, what was your experience? And through that process of asking, he says, oh, well, the doctor did spend more time with me and did ask me more about my smoking and then at the end of the conversation, I often get, yes, it really was more different than it felt. But when you're talking about admission, discharge, and transfer and a lot of the things that we do, it still hasn't reached a consistent level of performance that I don't think we're quite ready, because I don't want to have people react that they're disappointed that the reality hasn't caught up with the expectations that we've set. So we have to be a little careful, but I do think pulling the consumer in so that the consumer understands that this equates to a much more active participation in doing the things that's necessary to promote health but also manage conditions is really something that we all have to synergize the messages that we're originating, because that is a critical part to having a healthier state. It's sometimes, I sometimes do notice when I go to the states that tend to be quite healthy, where you go to Colorado or California or sometimes even New York City, where everybody seems really, on balance, a lot healthier than here. And I thought, well, how did they do that? They really, something clicked here, and I hope we can bring that back to Michigan and become one of the states that has a relatively low disease burden, because we've done a better job from a community perspective in taking care of ourselves.
Hi, Ed Sovey from Kalamazoo CMH. Question for Mr. Harding. I'm just wondering about all those cool integrations you have going. What are standards-based? Who insisted on the use of which standards? Or can you just talk about that? Or are most of these interfaces that are happening more proprietary in nature?
So PICS is a PC platform that is a VQO. And so I'm not the technology guy, so I don't know what standards are being utilized to share this information. I just know the end result of what we get from it. And so, sorry. Okay. You able to answer that? Because
Not authoritatively, I shouldn't try.
Okay.
I resist the temptation to make something up. In the back there?
Hi. That was almost the exact question I wanted to ask. So I wanted to make sure I heard you say that PICS is the PCE system, HIE is?
PICS is the Health Information Exchange, but the vendor is PCE Systems.
Okay, thank you. And then I'm wondering now then if, to step back to maybe more your area of expertise, what was the engagement process like with corrections in particular?
The correction piece is our next step in this.
Oh.
So we have not, we're going after a grant right now to be able to facilitate the operations of that, but the others are all operationalized.
And is that something that you're in charge of in terms of working with new sources of information to get them engaged in exchanging information?
Yeah, we have a strong partnership with our Sheriff's Department and the Juvenile Detention Center and have for many years. So this is something we've been talking about with them for at least 3 years, and actually have already communicated with their vendors and BizStream is a big one here in Michigan, and then the clinic that's within the jail system, the adult jail system, actually has approximately 75% of the United States are within their correction systems in the jails. So if we're able to be successful in this is something that can be opened up nationally to be able to do so.
Thank you.
Other questions? I have a question for Mike. From an IT perspective, we've said, hey, this one-way mirror concept is probably easier because we got all the SAMHSA weirdness. Let's push all the information to the behavioral health folks so they have a 360-degree view. But it sounds like that's not enough. What are the physical health people doing with that behavioral health information that's sort of important?
Believe it or not, when we started giving this information to the physical health entities, it wasn't necessarily the clinical notes. They loved the clinical notes. They loved the med reviews, the psych evals, all those items. But the biggest bang was the care team. Knowing who to pick up the phone and call in the event when there's an emergency. So, we spent all this resources on getting all these other documents in there, and just a simple thing of knowing who's involved in their care to be able to pick up the phone and find out more about the consumer was the biggest piece. Don't get me wrong, they used the rest of the stuff,
Sure.
but.
I'd like to just add that one of the other values of the ACRES file is, when you think about it, if everybody is putting the ACRES file in, we now know who all the participants in the care process are. And even before we start giving MedRec documents, we can have a chance at least knowing who are the other caregivers and try to coordinate things with them. And with all of those caregivers being simultaneously notified when people went to the emergency department, you can start to think, oh, they went to the emergency department with, let's say they're a binge drinker and they've been good for a long time, and now bang, they hit the ED. Everybody can realize now's the time to intervene on that process, and they can coordinate their efforts. So we haven't put all the use cases together yet to get that done, but part of the infrastructure is we need everybody to have those ACRES files in order to make that worthwhile.
Other questions? One more.
So going back to the $1 million question about confidentiality, Michigan Mental Health Code, 42 CFR, and HIPAA. What are we doing to create a sense of urgency to do that? Because even Dr. DeSalvo had mentioned that this is going to take some time, and this is a highly vulnerable population where we still have limitations. How can we break that code to facilitate and expedite that issue?
Yeah, we've been working within the confines through that consent process of being able to, identify to whom they want to share that information with. I know there's a lot of things that are happening nationally to change policy to break down that restriction of sharing to whom. I don't know enough about that information, but it's something that we've been able to build it in the technology with what we have today. It would certainly make it a heck of a lot easier if we didn't have to have this to whom you're going to share this information with, so that we could combine a lot of these health information exchanges and not have a behavioral health exchange and then a physical health information. And then on the ground of staff trying to use two portals, it's harder to get them to adapt to it and use it. And you probably
Yeah,
know
so,
more.
we have a group that does CMH and the PIHP CIOs have been really instrumental in helping push forward. That's been looking at e-consent and sort of the pieces are all primed and ready to go. There's sort of a request kind of sitting with the state to sort of fund advancing e-consent. It solves a lot of problems related to where SIM is going to head on a large scale, when consumers start doing more and more in the process. So we're kind of at the tip of the iceberg where I think over the next 18 months, 2 years, you'll see sort of statewide e-consent infrastructure, but you're not going to get around the problem of the federal laws that are requiring very explicit, proactive consent to share requirements. And possibly for right now, that's a good thing. One of the biggest issues is asking an individual to enumerate, every single entity and individual when it's kind of confusing. What is the legal entity that might be a big umbrella organization, or the smaller little entities, or the individual doctor that they know and trust? That just starts to be kind of scary to get somebody to try to acknowledge all that, let alone the mechanics of putting that big long list of possible folks on the form. And having it be electronic. And so there's pieces coming, but I don't see an elegant solution that we could flick a switch on. So.
Yeah, and one of the things, how we've implemented it is we know we kind of have this network of frequent flyer providers that our consumers go to. So what we do is we engage with the consumer when we're talking to them, and we actively ask those questions of, okay, are you seeing it at Packard? Are you seeing it at St. Joe's? Are you seeing it at University of Michigan? And they say yes, yes. And then, and are you willing to share your behavioral health information with them? And then they identify that. And then that information gets put into the e-consent management system to be able to be that key to turn on the ability for them to be able to view that physical health information. And it was really key too, because when we went live with the e-consent piece, St. Joe's is still the dotted lines on my diagram where they're onboarding this summer. So when they go live, they will actually already have the consent in place because they've already identified them on the consent. So having that kind of, I don't want to say pre-populated because it's not pre-populated, but that kind of standard who do you go to has helped us tremendously to be able to, when we start flipping the switch for people to come on board, the consent is already in place to be able to share that behavioral health information.
So we envision the active care relationship infrastructure as enabling the filling out of that form with the sort of most likely candidates that you would want to empower. Any more questions? One more, all right.
Maybe you were just addressing this, but I understand the role of acres in sort of being the traffic light to get the ADTs to the right place. But what is the vision for how you would share that back to the providers in terms of who all the other providers are that are claiming that patient?
So I think the question was, because I think it was about acres, is
And
how
the providers are.
how would we share back the active care relationships? And some of it is dependent on, again, some funding from the state, but the next stage in acres is to essentially serve that up to the trusted data sharing organizations as an ability to kind of look at everyone with an active care relationship. Now it will, we're treating an active care relationship with a behavioral health specialist as falling under more than normal HIPAA requirements, okay? So you're not going to see the full picture without consent, right? But you'll see everyone with an active care relationship, and you'll also see the entities that are sort of claiming a relationship, and ultimately the programs, okay? And so what it can begin to do is kind of serve up what are all those touch points or contact points. It'll be served up as a web service, which in modern day language means a FHIR resource. Dr. Jeff Eastman has sort of already, worked with the FHIR community to sort of package what that would look like for folks to consume. And then in something that's an evolution of our health provider directory, which is sort of based on Salesforce, there'll be a set of tools for folks at kind of a floor level to kind of manually look that up and potentially manage their active care relationships if that's the kind of tool they want. Otherwise, they can get at it electronically. But they'll have to be in the trusted community to sort of query and see that. But more and more, that'll become a nice way to kind of understand what is going on. And then over time, as those active care relationships become inactive but historically relevant, we'll kind of have different ways to serve up the history of those active care relationships. Does that answer your question, Claire?
I'd like to add that when they talk about they need more money, we at Blue Cross would be interested if there are health systems or other large providers that would be interested in co-sponsoring use cases with us that have such a clear need as this. It would just be so nice if when the ADT arrived, the list of all the providers with a care relationship who received that notice coming along with it, for example, could be a use case that could be funded. But it's really got to come from the provider community to say this is what we really need for a functionality because we understand how our processes work. Blue Cross doesn't have that insight. MiHIN doesn't have that insight, but we can work together to really do it intelligently. And we would be interested from the Blue Cross perspective in hearing about others who might want to co-sponsor such a use case. So it's not just the state of Michigan, it's all of us who should be thinking about we get these capabilities because we realize the value and we actually contribute resources to make it happen.